Good evening and welcome to the 2025 Annual Immunisation Update. My name is Phoebe James. I'm a Professional Development Officer for the Hunter, New England and Central Coast Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands that we all meet on today. We are coming to you from Awabakal and Warramai land and pay my respects to elders past, present and any First Nations people joining us this evening. Just some housekeeping before we begin. As always, the wonderful team will be working behind the scenes answering your questions online. We are going to aim for a 10-minute break around 7:30. Depends on how quickly we can get through our content. For a certificate, please fill out the Slido at the end of the session. It is now my pleasure to introduce Sharon Saxby, Immunisation Clinical Lead. Sharon.
Thank you, Phoebe. It's really lovely to virtually see everybody and to be back again in 2025 for a really, really busy year of immunisation and lots of opportunities this year for our community. I'd really like to begin by saying our team were absolutely delighted to welcome Jodie back this year. Jodie came back to us in February and it's just been delightful having had her office so long. She's really missed chatting with you all and sharing her absolutely great wealth of knowledge. So call up, say hello. She's been very kind to herself as she dives back into everything that's happened while she's been away. We've also welcomed a new team member to our team. So Debbie Parker has joined us for 2 days a week. She's our registered nurse and her main task will be following up overdue children. So you may well be hearing from Debbie over the time. Debbie has worked in general practice for about 14 years. She spends her weekends and public holidays at GP Access and somehow fits in conducting workplace influenza vaccination clinics in her spare time. So she's in on Wednesdays and Thursdays, so call up and say hi to Debbie as well. There are a few presenters that were unable to be with us here tonight, so you'll be hearing a lot from just a few of us tonight, so bear with us. Sit back, make yourselves comfortable, and please send us all your questions and thoughts on Slido. We're just going to do a little quick update to begin with to see where we are and how we're going with rates. And I was given a really great article that was in the Lancet, just talking about the vaccine situation we have going globally at the moment. And I just want to read a comment that seems to set the scene. It seems ironic that Robert F. Kennedy Jr., one of the most prominent anti-vaccine activists, has been made Secretary of Health and Human Services in the USA, while one of the largest recent measles outbreaks is spreading unabated in Texas and beyond. Note, the US is not the only country with the resurgence of measles. In 2023, there were 57 countries which saw large and disruptive measles outbreaks, which is an increase of 58% compared to 2022. Almost half of all outbreaks were in Africa. So this is an enormous problem. Measles is a poignant example of failures in the current vaccination ecosystem, including the role of misinformation and lack of trust in vaccination. So I think in Australia we need to be really careful that we are not immune to all of this. So let's have a little bit of a look at our rates. Are we actually prepared? We hear of measles coming in now, but are we actually prepared? I love that sign on the truck that says, "Don't hesitate, vaccinate." A message that doesn't seem to be getting through. So in Hunter, New England, we like to measure our children and see who's fully immunised. So just remember at 12 to 15 months, here we're measuring vaccines given at 6 weeks, 4 months and 6 months. And we can see here they're tracking along. The red line is our non-Aboriginal children and the blue line is our Aboriginal children. You can see way back in 2020, we'd actually closed the gap. We were doing brilliantly, but that gap has progressively opened up again. And we can see that we are managing to get our Aboriginal children vaccinated at a greater rate this last quarter, but our non-Aboriginal children not so. And we're still not hitting that magic 95% mark. At 24 to 27 months, we're measuring vaccines all the way up to 18 months. And we can see here that we're actually gradually closing that gap again, which is absolutely fantastic news. Our Aboriginal rate at 91.3 has stayed steady for the last few quarters, and our non-Aboriginal rate is actually coming down. So we're sort of not closing the gap in the positive way, we're just closing the gap. So there's a lot of work to be done here, considering that this is measuring our 2 doses of measles, mumps and rubella as well. At our 4-year-old kiddies, the 60 to 63 months, well actually 5, and I'm sorry I've left one of the other data sets in there, but we can see that for both cohorts, our rates have decreased. So we're sort of closing that gap again, but in the wrong direction, although we are at the 95% mark. But this is only actually measuring the DTPA IPV that's given at 4 years of age. It's not measuring all their other vaccinations. There's an assumption that they've all been given if they're receiving their 4-year-old vaccines. So be alert and be checking all of your children that come in. So what do we do when we know that there's pockets of children who are under-immunised? In Hunter, New England, we've been rolling out what's called TIP program. So it's tailoring immunisation programs. It's actually been developed by the WHO, and it identifies those populations with lower coverage rates. And it uses a lot of qualitative research and discussions with providers and community to understand the reasons why people do and don't vaccinate and explore barriers and other facilitators to vaccination. So we've been doing a few of these in Hunter, New England over the last several years. Maitland has been going for quite a while with some really good success. Tamworth is just underway at the moment, looking at Aboriginal children. And we're about to embark on one in Lake Macquarie because we've identified pockets of low immunisation rates there as well. Just a really great picture to show that immunisation can happen anywhere. This is up in Moree, obviously home visits, just outside the front door. So it's all about being creative in how we get our vaccinations done, and just remembering that a recommendation from you to immunise is one of the most powerful tools that there is. Parents trust you and they trust the advice that you're going to give. Potentially allowing families to drop in for vaccinations. I'm sure lots of you send reminders, an email or SMS, and check up with the children. Make appointments for the next immunisation due when you're seeing them at the moment, and opportunistic vaccination. And I know not everybody's bulk billing, but exploring the opportunity to bulk bill if possible for children at least for their immunisations. Sky has got some great information, the website, on empowering immunisation conversations. So if you haven't actually explored that website, have a look. It's just really important to know that overall, and it's not just in childhood vaccinations, but in school vaccination rates, adult vaccination rates, we are seeing a decrease in people being vaccinated. It's really been hard to understand why that's happening. Lots of things. We talk about COVID being the issue, but we can see that vaccination rates were sort of decreasing a little bit before COVID. So we need to be really aware of this and just understand that our relaxing attitudes towards vaccination will leave us all at great risk to disease re-emergence with the decreasing vaccination coverage rate. So really important to be on the alert and be looking after your children. So great thanks to you all. You do an absolutely fabulous job. And did you know you were a lifesaver? I'm going to hand over now to Georgia to give us an epidemiology update.
Great, thanks. Thanks, Sharon. So hi everybody, my name's Georgia. I'm a CNC with the Communicable Diseases team here in Hunter, New England, in the Public Health Unit, and I'll be giving the Communicable Diseases update tonight. So thanks, Phoebe, for that lovely acknowledgement. I'd also just like to acknowledge and thank the Awabakal people for allowing me to present to you tonight from their beautiful lands, and I pay my respects to all their elders. So we'll start with a quick respiratory update. So this is from the New South Wales surveillance report, the Epi Week 10, so ending the 8th of March. So COVID-19 activity is currently at low levels, but there's some indication of an increase currently. Influenza is at low levels and RSV is currently at a moderate level. These are the trends we would expect to see at this time of year. And the little graph there, so that is the COVID-19 wastewater surveillance program. So our Hunter area is Burwood Beach, and you can see there it's just reflecting the low levels reported in Epi Week 10, and it's tracking well below the last peak, which was in late January. And that's when there was moderate levels of COVID activity in the community. Quick look at pertussis. So notifications for pertussis in New South Wales started to increase in 2023, with 2024 having the highest notification rate recorded since 2009. The number of notifications in our school-age kids, or 5 to 14-year age group, increased rapidly from February last year and reached a peak in September. But then in November, notifications in this age group started to decline and is now comparable with all the other age groups. Just recognising the huge workload that pertussis was for everyone last year, but it's really good to see that the numbers have started declining and they're holding steady coming into winter. We'll just have a quick look at some insights from the international experience in winter, which is just finishing, so 2024 to 2025. High influenza activity across Europe and very high across America, with the flu A strain being dominant for both. America has classified this flu season as high severity for all age groups, and this is the first time in 7 years, that they've had this, with reports of rare and severe outcomes in children. So it is complex to predict the winter respiratory season in New South Wales, of course, but we can definitely draw insights from this. Okay, looking now at invasive meningococcal disease, or IMD. So this graph highlights essentially in H&E over the last 3 years. So noting the last 4 months, there has been a sharp increase in IMD notifications. So November last year recorded a significant increase, which peaked in January and continued on into February this year. Prior to this, notifications were much lower and much fewer, as you can see. We've had both serogroup Y and B, with a wide range of age groups as well as clinical presentations. Of course, both serogroups are vaccine preventable. It's also important to note that in January this year, H&E recorded the first residential aged care facility cluster of IMD, and there's also limited literature worldwide of any other institutional-based outbreaks. So this was a really significant event for H&E to start the year off. Okay, getting into the hot topic of measles. So measles anywhere is a risk everywhere. So ongoing outbreaks globally, of course, increase the risk for us here. Measles is one of the most infectious viruses affecting humans. And it's really important to have a high index of suspicion in people who have and have not travelled with a clinically compatible illness. So just looking at the clinical alert there, so 10 cases in New South Wales this year. We've had 5 overseas acquired with 4 locally acquired. We've had none for H&E yet, but we've had 1 close next door in the Central Coast. So this is the GP alert that everyone should have received, that we'll just quickly go through. So what's your role in early detection, prevention and management? So why does it matter for GPs? So early recognition reduces complications and the ongoing risk of transmission. It's a vaccine preventable disease, and there is potential travel-related risk. So what to look out for? Clinically, the prodromal phase, so that's 2 to 4 days before the rash appears. So fever, it's often quite high. We've got the 3 Cs and the Koplik spots. So that's a small white spot seen in the inside of the mouth. And then usually the last clinical symptom is the rash. So starts on face and spreads downwards. And that will normally fade over 5 days, followed by skin peeling. So what to do? Test. So we want a nose and a throat swab, as well as a first catch urine for PCR testing, and also bloods for measles serology. Make sure you mark urgent on the request form, and the public health unit can also help expedite any testing with labs if needed. Isolate, very important, so get them to return straight home, single room if available, and add respiratory precautions immediately. Even while you're sitting there in the consult, if you just pop a mask on, that's going to greatly reduce the risk to others. And of course, notify us on clinical suspicion of fever and rash, which you guys are doing anyway. This is a really good tool if you've just forgotten everything I've said. Get on to New South Wales Health and have a look at this triage tool. Print it off, pop it on your desk. Okay, moving on to the next hot disease is Japanese encephalitis virus, or JEV. So again, another release, media release from New South Wales Health. So this was released last week, announcing 5 infections of JEV within New South Wales this season. So there's a lot happening in the state, but just focusing locally, We've had one confirmed and one probable case within H&E. We've had no deaths, thankfully. Both cases are up on the Queensland border, but in different areas to each other. Neither were vaccinated against JEV, and one was in a vaccine-eligible area. So the JEV has been detected in our environment here in H&E. So we've had both mozzie detects and feral pig detects, all in different areas. So Moree, Tamworth, and up near Ashford. Okay, so again, what's your role and why is it important? So it's rare, but there is a high mortality rate. So about 1/3, sadly, of cases will end up dying. 1/3 will end up with permanent or severe neurological deficits. So really important to get onto this if you can. So again, early recognition reduces complications. It's a vaccine preventable disease. And then again, the potential travel-related risk. So what to look out for, just your normal, flavivirus kind of symptoms: fever, headache, vomiting, malaise. The acute encephalitis phase, most likely not going to present to you in primary care, but more to a hospital, but still really good to note. So seizures, confusion, stiff neck, weakness in limbs, and ataxia. When clinically assessing your patients, really important to ask occupation. Do they work in a piggery? Do they work outside? Any recent travel? So this is overseas, but also within Australia. And also, what are their hobbies? So feral pig chasing, camping, fishing, anything outdoors. What to do? So CSF and blood serology is the gold standard. CSF and blood PCR, really low sensitivity and not recommended as a standalone test. Flaviviruses will often come back negative on a PCR, so that can't be used as an indication. It's the serology that we like. And of course, imaging, so CTB, MRI. And really important to rule out other causes of encephalitis as well. Consult with ID at the John Hunter Hospital. They're always available on call via switch. And of course, contact us at the Public Health Unit. So there's no treatment for Japanese encephalitis virus, so prevention is the key. Besides vaccine, bite prevention and mozzie control are the best ways to protect yourself from getting the environment. So lots of ways to do that, lots of resources online. I'll just go to the next slide. So lots of useful links for measles and mosquitoes. And I think I'll hand that on to Sharon next. Thank you.
Thank you, Georgia. That set the scene beautifully for the rest of our evening. Lots of hot topics out there this year. So we're going to talk about a few of them. So number one is RSV. Already there's lots of questions about RSV and RSV vaccination. So strap yourselves in. I know it's a little bit bits and piecey, so we'll do the best we can. So just looking at RSV worldwide, in 2019 it was estimated that for children under the age of 5 years there were 33 million RSV-associated acute lower respiratory tract episodes, with 3.6 million associated hospital admissions and over 100,000 RSV attributable deaths. Now, about 46,000 of these were deaths in infants under the age of 6 months of age. So this is an absolutely devastating disease and a very common disease. Unlike COVID, the RSV vaccine has been in development since 1960. So this has been tried, tested, tried again, tested again. We have a very reliable vaccine now. Thank goodness. So looking at the risk of RSV in Australia, we can see here in the circles that really it's our under 12-month-olds that are at greatest risk of RSV serious disease and hospitalisation. And you can see on the right that per 100,000, our Indigenous children are really overrepresented in these cases. So we've got a lot of work to do here, and the vaccination program that we have now is playing a really important part in lowering those numbers. It will be delightful to see next year if we see much lower rates of RSV disease. We can see here, this is New South Wales data. So for children under the age of 12 months of age, they're actually 34 times more likely to get RSV and be hospitalised with serious illness than the total population. So this poor, young, vulnerable cohort under 12 months of old are paying the highest price of RSV disease. We know that RSV is seasonal, and in New South Wales it lands with us in the early winter and winter, so between March and September. So that's why we've rolled out the vaccination program now, or the nirsevimab program now, to be in time and have these children protected before we hit the RSV season. Most of you, I hope, are really familiar with the fact that we've got a two-pronged approach to our RSV prevention program this year. We have maternal vaccination, which rolled out on the 3rd of February 2025, and we have the nirsevimab program for babies, which rolled out on Monday, on the 17th of March. I'm really hoping that by tonight we can explain it all for you and have it simplified, because it affects different people with what they're actually providing for their mums and their babies. So we'll start with the Brisvo, which is the maternal vaccination. The Australian Immunisation Handbook has been updated, so it's got all the recommendations in there. So it is a single dose of a Brisvo, recommended for all pregnant women at 28 to 36 weeks gestation, and it's recommended to be given at the 28-week antenatal appointment. It's not recommended to be used earlier than 28 weeks gestation because we're just waiting for safety data on that, but if it is given before 28 weeks, we don't repeat it. You can also give it after 36 weeks gestation, but that infant may require nirsevimab if they're born less than 2 weeks after mum received her Brisvo. A really important note is that there are 2 RSV vaccines out there, a Brisvo and a Rexvi. A Brisvo is the only RSV vaccine that's registered for pregnant women. Okay, a Rexvi is not. So this is going to be a year-round program, so it's not just pre-RSV season, it's for all year round. And if you've got any women who are already greater than 28 weeks pregnant, please offer them the vaccine ASAP. It can be safely administered with DTPA, influenza, COVID-19 vaccines as well, and your anti-D as well. So what is a Brisvo? It's a recombinant respiratory syncytial virus. It's a pre-fusion F protein vaccine. Unfortunately, it comes as a powder and a diluent, so it has to be reconstituted. So at the moment, as far as I'm aware, it only comes in single doses, but if it comes in boxes of 10, can I please just urge you to be really careful and make sure that you get out both the diluent and the powder, and don't get to the last diluent and find that you've still got 3 powders in your box because somebody hasn't received a vaccine. It's by intramuscular injection. The only absolute contraindication is anaphylaxis to a previous dose of a Brisvo, which they probably haven't had, or any component of the RSV vaccine. And just that precaution about not giving earlier than 28 weeks gestation while we await safety data. What about adverse events associated with vaccination in pregnant women? We can see here that in the studies, it showed that injection site reactions were more common in the vaccinated group of women, but we expect that with every group of vaccinated women to be injection site reactions to be greater than a placebo. And the most common was injection site pain. As far as systemic adverse events goes, there was very little difference here, and the most common being fatigue. But if we look at the group of women that they're actually studying, between 24 and 36 weeks gestation, we would assume that fatigue is a very common adverse event from pregnancy. So this is not to be unexpected. There was no difference in the rates of serious adverse events in pregnant women, and there was no difference in the rates of serious adverse events in babies born to women who'd received a Brisvo. So a fairly safe vaccine. It's worth mentioning that in the first studies, there was a little bit of a slight concern about increased rates of preterm birth and babies small for gestational age. But in the washout, when they looked at it and they studied the data, they could see here that there was very little difference, and they were very reassured that this was a safe vaccine. You can see there that the US are actually doing it between 32 and 36 weeks, but when ATAGI have looked at all of the data, they've deemed that it's safe, and we're going to go for 28 weeks to 36 weeks to give that greater period for mum to develop antibodies and pass along to bub. Brisvo efficacy, we can see here by the orange line, which is the ones that were vaccinated, the efficacy rates is much greater than the placebo. So we can see that severe disease Within 90 days, the efficacy rate was 81.8%. So this is a really well tolerated and a very effective vaccine. So we should be very thankful that we finally have this vaccine. I think before the program rolled out, we all had maybe questions about how it would go down with pregnant women. We're advising that they have another vaccine while they're pregnant. They're already giving Boostrix and influenza and possibly COVID vaccines. So how are they going to go with another vaccine? It's really good to report that everyone I've spoken to that's given all the maternity units and antenatal units that have been giving lots of Abrysvo have been saying that women are asking for it. Women are very aware that this vaccine's out there, they're asking for it, and there has not been any talk about not wanting to have this vaccine. So that's really, really encouraging. If you do, you may have some people that will ask you, how is their baby going to benefit from receiving vaccine? Obviously from the antibodies passed through the placenta. How safe is it in pregnancy? And what do they do if they decide not to get Abrysvo? How is Bubby going to be protected? So just reading all your resources and you being aware of all of this information will help you with your conversations with these women. Vaccination records. You know that we as a team love vaccination records and we love AIR. And we really love the fact that you put all your vaccination records onto AIR because that is the one source where everyone goes to see if people have been vaccinated. So please, every dose of Abrysvo you give, make sure it goes onto the AIR and make sure you mark that mum as being pregnant at the time because AIR collects that data as well. That information is not only going to help us know for mum's sake whether she's been vaccinated, but it's also going to help us to identify infants whose mother did not receive Abrysvo and will now require nirsevimab once they're born. So please ensure that these records go across. NCs have got some great Q&As, or FAQs, I'll get that right at some point, on Abrysvo. So please, if you don't usually look up NCs, please make yourself available of that. And they have some most of the questions that we all ask, they've got some great answers to there on how safe Abrysvo is. Now I want you to pay really close attention to this slide. So this is the RSV vaccines and the immunisation products for RSV, who they're registered for and who they're funded for. So we can see here that we've got Beyfortus, which is nirsevimab, we've got Abrysvo, and we've got Arexvy. The green boxes show you who it's actually recommended for and funded for. Okay, so Beyfortus is only for infants and children up to the age of 24 months. It's not for adults, it's only for children. Abrysvo is a vaccine. Abrysvo is registered for both women in pregnancy at 28 to 36 weeks and adults over 60 years and over, but it's only funded for pregnant women. Arexvy is the other vaccine, and it is only registered for people over the age of 60 years, and it's not funded. It's only available on private script. So please, we don't want to see babies receiving Arexvy or Abrysvo, and we don't want to see mums receiving nirsevimab. The infant nirsevimab program. It commenced on Monday to much great delight and to some horror, I think, from some people who were a little bit unprepared. So what is nirsevimab or Beyfortus? We're going to call it nirsevimab. It's a monoclonal antibody. We have talked about this before. What is a monoclonal antibody? There was a lot of confusion about whether it's a vaccine or not. It's not a vaccine, but it immunises. Okay, so it prevents infection by a process called passive immunisation. So we're creating the antibodies somewhere else and we're just delivering the antibodies to the baby so that that baby has the antibodies to fight that infection. Those antibodies are going to dissipate after about 5 to 6 months. When we give a vaccine, we're creating somebody's body, we're inducing somebody's body and immune system to create their own antibodies that they then have with them. So passive immunisation for these babies is created through maternal vaccination and by giving nirsevimab. All right, this is a sticky bit. There's 3 different eligibility criteria for newborns, for children receiving nirsevimab. The first one is for newborn infants. So this is for infants born to mothers who did not receive RSV vaccine during pregnancy, or they were born within 2 weeks of the mother receiving the RSV vaccination, Abrysvo. They were born with risk conditions for severe RSV disease or to a mum with severe immunosuppression, even if mum had been vaccinated, and whose mothers who've received the RSV vaccine in pregnancy but have undergone such treatment that has led to a loss of maternal antibodies. All of these eligible infants should be receiving nirsevimab prior to discharge from hospital. And there is a great decision aid tool to use as well, and we'll look at those in a bit. The second group for nirsevimab is for infants up to the age of 24 months who remain vulnerable to severe RSV disease through into their second RSV season. So these are infants who were born from the 31st of October 2023 to the 31st of October last year, 2024, without any known prior RSV infection, but they have risk conditions for severe RSV disease. Okay, they're clearly outlined in the immunisation handbook, and you can see here what they are. So their dose is recommended from mid-March 2025. You can see here that we've got the preterm birth, less than 32 weeks, hemodynamically significant congenital heart disease, significant immunosuppression, chronic lung disease requiring ongoing oxygen, neurological conditions, cystic fibrosis, and trisomy 21. If they are receiving their second dose, there's a recommended gap of 6 months between their first and their second season dose. Now, these eligible infants can receive nirsevimab through either their GP, AMS, or community health centre. Now, there's a third category, and this is New South Wales specific, this one. There's a catch-up program which goes on the 2024 program eligibility criteria. So this is for babies when the program ended at the end of October last year, 24. So if babies born from the 1st of October 24 to the 16th of March 25 when the new program started. So the criteria here is what was eligible for last year. So infants not protected through maternal RSV vaccination did not receive nirsevimab at birth and to meet one of the following criteria. Infants born less than 37 weeks gestation, or Aboriginal or Torres Strait Islander infants, or infants with risk conditions for severe RSV disease as per the handbook, which is what we looked at a minute ago. And there's another great decision tool that's available that outlines all of that. These infants can receive their nirsevimab from their GP, AMS and community health centre as well. Really important to see when we've been talking about immunisation rates and the fact that our Aboriginal babies are so overrepresented with RSV disease is that in that period, all Aboriginal and Torres Strait Islander babies were eligible for a dose of nirsevimab. So it's worth having a look back through your Aboriginal and Torres Strait Islander babies who were born in that period and be reaching out and ensuring that they've been offered a nirsevimab. So these are the decision aids. All of these are on the New South Wales Health website for RSV prevention program under resources. So these are really good and clear and lead you on a merry way down the page as to whether the baby will require nirsevimab. So please avail yourself of those. Who can initiate RSV immunisations? It's been added to the authorised immuniser authority. If you're not an authorised immuniser, you still need your medication order from the medical practitioner. So what does nirsevimab come like? Excuse me. It comes in 2 different doses, 2 different preparations. There's a 50 milligram and a 100 milligram. So how do we know who gets what? So if a baby is less than 5 kilos, it gets a 50 milligram injection. If they're 5 kilos and older, they're getting 100. For babies entering their second season, regardless of their weight, they're getting a 200 milligram dose. The issue here is it only comes in, the greatest dose that comes is a 100 milligram dose. So these babies are going to need 2 100 milligram doses or injections. Okay, we're going to give them at separate sites. When you go to enter these onto the AIR, unfortunately, you're going to only be able to enter one of those doses onto AIR. AIR will not let you put 2 doses of the same thing on the same day. So just enter 1 dose. No special handling requirements for nirsevimab. So how are we going to order our RSV products? There's been a lot of discussion about this, going backwards and forwards, and I think there'll be slight changes as we move forward as well. But both the Brisvo and nirsevimab are available to be ordered from the New South Wales Vaccine Centre, just through your normal ordering system. And just remember that these nirsevimab orders placed by AMSs, GPs and community health centres won't count towards your monthly vaccine ordering limit. So you have your 2 ordering limits a month. Just like flu, these orders won't affect that limit. So GP services, there's a little bit of different way that we can order vaccines. So for GP services, you need to complete the nirsevimab order form on the vaccine website page. So you go in, and when you go to place an order, you'll be given that little box up the top, and one of those little boxes is for placing an nirsevimab order. When you click that, you're going to get a form open up. Now, we've got great news this afternoon, just before we finished our slides, that form has actually been updated, and instead of 1 form per child, you can now use 1 form for up to 5 eligible individuals. So if you've got 5 eligible individuals that you've identified, do the form, put them all on one and place your order. So have a bit of a think about the kids that you've got in your surgery. Remember, these are not the children that missed at birth. These are the children that are eligible because they're at risk or in their 2nd year of RSV. So you can't actually GP services can't place an order for nirsevimab for babies who missed in hospital. Instead, the Ministry of Health actually want you to contact them if you identify an eligible baby who missed in hospital. They want to collate this data to see why that's happening, so it's really important that you feed back to them. They've also made an allowance that if you want to do a catch-up clinic, that you contact them to organise nirsevimab doses for that catch-up clinic. AMSs and community health centres are slightly different. They've been given the opportunity to actually ensure that they can pre-position nirsevimab doses at your service. So this allows for opportunistic immunisations, given that we have a lot of our Aboriginal babies that are may well have missed nirsevimab earlier in the old program. So they've allowed them to order things. So AMSs and community health centres out there, I would urge you to contact Ministry of Health at VAC reports and to order some doses to be pre-positioned. Because if you don't do that, you have to fill out that form as well for every 5 babies. And if you identify a baby that was not given nirsevimab prior to discharge from hospital, you also we encourage you to contact VAC reports as well to report that. There are lots and lots of resources out there. New South Wales Health have got a lot of resources on their page for pregnancy, during pregnancy, after pregnancy. We have some Aboriginal focused resources and others as well. Lots of great websites to point your mums to, lots of resources that you can order and have ready to hand out as well. Pfizer also have some good resources. If you would like to contact them for a Brisvo. The Commonwealth NIP has lots of resources as well. Everyone's in on the resource game. Clinician resources, I would just advise that you go to New South Wales Health website. They've got a lot of topics there. As you click on them, it's going to take you to all the different resources. It's going to take you to the eligibility clinical tools, eligibility criteria, etc., recommendations, storage, efficacy, everything you might want to know should be on that page. So save that as a favourite. Can I recommend that if you haven't watched the NCIS webinar on RSV, that you do so? If you just go onto their website page, or if you just Google NCIS webinar series, you're going to find that update, and I would really recommend that you watch that. Okay, our next hot topic, measles. You've heard a little bit about measles. I spoke about it, Georgia spoke about it. It's there. A really good quote from that other article I was telling you about from The Lancet was saying that measles is a canary in the coal mine for under-vaccination, be it due to vaccine information, lack of access to vaccination or conflict. As such, we unfortunately can expect more outbreaks in the coming months and years, and knowing the facts about measles information and disinformation is the key. So that poor baby there. It's very sad, measles. So measles, we know, vaccine preventable. Very effective vaccines, only 2 doses. So why are we not seeing this effective vaccine being given? The recommendations are children, 2 doses at 12 months and of course at 18 months combined with varicella. It's also recommended for all adults and adolescents born during or since 1966, And they should either have 2 documented doses at least 4 weeks apart, with both doses being given over the age of 12 months of age, or have serological evidence of immunity to measles, mumps and rubella. You can see that measles alert that was on the right that Georgia was talking about before. So we have to take this really, really seriously and be suspecting measles whenever we have cause to. Just remember that for children, those 2 doses can actually be given from the age of 6 months if they're travelling to a high-risk country. And also remembering that we're talking about 1966 when we're talking about 2 doses, because before that there was lots and lots of circulating measles virus and disease were very prevalent, and most people would have acquired immunisation from natural infection. If in doubt, vaccinate. What are the vaccines? So we have 2 lots. We have MMR and we have MMRV. We've got Priorix and MMR2, which are your live attenuated vaccine. For whom? These are registered for people 6 months of age and older. It's 0.5 ml, single dose. Please make sure you check AIR, that favourite website of ours, check AIR and the patient record for any live vaccine given within the previous month, okay? Because you give that second dose earlier than 1 month and it's not really a valid dose. It's going to interrupt the process. Immunisation by IM or subcutaneous injection. And we have MMRVs, Proquad and Priorix Tetra, another live vaccine registered for people 9 months of age to up to the 14 years of age. Single dose, once again, check AIR and by IM or subcut injection. Just remember that any measles containing vaccines administered prior to 11 months and 1 day are not counted towards the 2 recommended doses and should be repeated. My last favourite hot topic is Japanese encephalitis. So Georgia gave us a really good rundown on Japanese encephalitis. Fairly new to the country, but really serious, and it's really gaining momentum. So those pesky mozzies are pesky for a very different reason now. You might be familiar with the eligibility for Japanese encephalitis virus vaccination, very effective vaccines, but this really is the eligibility. So for people 2 months of age and older, and who live or routinely work in any of the LGAs of high concern, and we'll talk about those in a minute. And basically, the bit in red is all you need to worry about. If they regularly spend time outdoors, or as David Durhammer says, if they just spend time outdoors, that's all we need. They're eligible for a funded vaccine. So if you live in the Newcastle area or whatever, you may well have people who go and work in the areas of high concern. You can vaccinate them here and send them merrily on their way. So where are the LGAs of high concern? Basically, it's west of the Dividing Range, except for Upper Hunter. They're just a little bit next to it. So anything west of that Great Dividing Range is an area of high concern, and we should be offering vaccination. Unfortunately, we're not seeing vaccine being ordered and distributed at rates that we would like. GPs are the number 1 who are actually ordering vaccines, closely followed by pharmacies and AMSs. But we can see just in the last 30 days, it looks really good. We had 1,100 or nearly 1,200 vaccines distributed in the last 30 days, but how many of those were actually given? So vaccine administration has picked up. You can see there since Christmas or just before Christmas, it really took off. And this was administration. But if you really look, the numbers are not great. And we can look here for Hunter, New England. These are the areas that have ordered or administered the most vaccines. But if you look in that far right column, the highest was only 56 people per 100, per 1,000 of population. So we're not covering and protecting a great number of people out there in the population who are eligible for these vaccines. So I just encourage, please, if you live in any of those areas or you're sending anyone out there, ask. If they've been vaccinated, explain what vaccination is, offer the vaccination and vaccinate. What are the vaccines? 2 different vaccines. We have Imagev, which is a live vaccine, and this is registered for people 9 months of age and older. It's a single 0.5 ml dose. Just make sure, once again, that you check AIR and the patient's record for any other live vaccine given within the previous month, and it's by subcutaneous injection. That is the preferred vaccination. So you can order lots and lots of Imagev. Jespect is our inactivated vaccine, and it's for people 2 months of age and older. And there's 2 different doses. So from 2 months to 3 years, it's actually half a dose at 0.25 of a mil, and it's 2 doses 28 days apart. For 3 years and older, it's half a mil, 2 doses, 28 days apart. It's administered by intramuscular injection. So the Vaccine Centre prefers that you use that only for people that can't have Imagev. So order lots of Imagev and order a little bit of Jespect and use those for people who can't have Imagev. So who can't have Imagev? So contraindication absolute obviously is anaphylaxis to any dose of JE vaccine and after any component of a JE vaccine. Now obviously Imagev is contraindicated in people who are immunocompromised and in pregnant women because it's a live attenuated viral vaccine. Women should avoid pregnancy for at least 28 days after vaccination. Breastfeeding women should not receive Imagev as we don't know whether it's excreted, the live virus is excreted in the breast milk. We might say we all know not to give live vaccines to pregnant women. That is not the case. We had one just recently. So we just need to be really, really careful about what we're giving and who we're giving it to and really know our information. Our precautions is for immunocompromised. So Jespect is the inactivated vaccine, not expected to cause any safety concerns, but immunocompromised people may not mount an adequate immune response, just remember that. Breastfeeding or pregnancy, vaccine is not really routinely recommended, but if they are at risk of acquiring JE, then Jespect is the recommended vaccine because it's an inactivated vaccine. And we're talking about everyone west of that dividing range is at risk. No adverse outcomes of pregnancy has been attributed to Jespect, and there's been no specific data using Jespect in breastfeeding women. But all of this information is in the handbook, ready for you to look up. So thank you very much. I'm going to hand over to the brilliant Kirsty Waller.
Good evening, everyone. So, yeah, my name's Kirsty. I have presented quite a few times before, so thank you for joining us. So this evening I'm going to talk firstly to you about the New South Wales School Vaccination Program for 2025. I'm now in the School Immunisation Program Coordinator role. I share that role with our wonderful Lisa Gray, who unfortunately is at home unwell this evening. So any school vaccination program questions at all, please direct them to myself or Lisa. Yeah, we'd love to take your calls. So for the 2025 program in the school vaccination program, nothing's really changed significantly. For our Year 7 students, we are still offering a single dose of DTPA vaccine, and in the school program that is Boostrix, and a single dose of the human papillomavirus vaccine or Gardasil. And for our Year 10 students, a single dose of meningococcal ACWY vaccine. And the vaccine that we are now offering in the school vaccination program this year is Mencodfi. You will notice on the immunisation schedule in February that changed to show that our Year 10 adolescents are now recommended to receive Mencodfi. Now, if you don't have Mencodfi out there in GP practice in your fridge, and you have a Year 10 student that has presented, and you have Nimenrix in your fridge, which was the vaccine that we have always been using previously for meningococcal ACWY, please still provide that vaccine. There's no problem in doing so. It's just that Mencodfi is now funded for that adolescent group, and Nimenrix is now funded for our little ones, for our 12-month-old bubbies. So, but as far as vaccine ingredients go and antigens, there's really not much difference at all. But in the program, in the school immunisation program, for any of those nurses out there that are working with us within our teams, you all know that we only are allowed to deliver Mencodfi in our program. So how do parents provide consent for their school, their student to receive vaccines in the school program? As hopefully most of you know, 2 years ago, in 2023, we moved to an online consent process called CARMI. So we certainly are encouraging our parents to provide online consent, and this is via a URL or QR code. This information is distributed to our schools early in the term 1, And the flyer that you see there on the screen, that has actually been sent as a hard copy to all our schools with the intention for that to be delivered given to all our Year 7 and Year 10 students within those schools for them to hopefully take home and give to their mum, dad or carer. So it hopefully is an easy way for them to provide consent. Now, we will always have a hybrid system in the school vaccination program, and when I say that, I mean hybrid as to how to provide consent. There was the hope that we could move completely online with this system, but unfortunately that will never be the case. So we certainly still have paper consent cards available and out there. And please be aware that if you have patients that are unable to access the internet, or they don't actually have a Medicare number, or unable to provide Medicare details at all, or actually just unable to provide an online consent, that absolutely they're able to request a paper consent card through their school, and that should be given to their student and for them to bring home to complete that card. It does mean a little bit more extra work in the background for our team leaders out there, our nurses that are going out to the schools, because they actually have to manually upload those forms into their online system. But you know, that's by the by. We really want to make sure these adolescents aren't missing out on vaccines at school, and we know that our parents and carers really appreciate this program and the convenience of it. It's good for busy families. Okay, so if you have any parents with any questions at all about the school vaccination program, there's the New South Wales School Vaccination Program website, and this year it's actually all been revamped and it's really user-friendly. There's a section there for parents and carers and for students and for schools, and it's really good. There's a great little video on the landing page that goes for about 1.5 minutes, and it just explains the program in a nutshell, and that's actually the video that we show at our orientation events when we go out to the schools at the end of the year when we're talking to our incoming Year 7 families. So it's just gives a really good overview of the program. And also really important to note that we have consent material available actually in 28 languages as well. So who is eligible for catch-up in 2025 for adolescent vaccines? It's essentially, in the school program, any student with assigned consent. So we do offer DTPA and Gardasil vaccines to students. Like we catch them up quite actively up until Year 9, but if we have nurses out there at the schools that recognise, say, a Year 10 student or 11 or 12 that has not had their Year 7 vaccines, we are checking AIR to see that history, and if that's not picked up that they've had their vaccines, we will call that parent and get consent for them to hopefully receive them in the school program. So as I said earlier, the school program has moved predominantly online. So that then for us as staff within the program means that we go out to schools now with iPads, and it means that we can retrieve the student consents and we can record all the vaccination details. And the really big bonus about this online program is that we actually have access to the student's AIR record during a clinic. And also their vaccination records are uploaded to the AIR on the day of the clinic, and it's really very fast. Once the nurse hits mark as vaccinated, often the parent's getting a text message within the next 10 minutes or so to say your child has received their vaccine. So that's fabulous. It used to take us a long time to get school records uploaded to the AIR. So the fact that it's now fairly instantaneous is just such a bonus for everybody. Our school teams do make the most of every opportunity, and we'll always try and offer catch-up vaccination at every school visit. Generally, our teams are going to schools at least twice a year and hopefully 3 times a year. But some students do prefer to attend their GP to have their vaccines done, to go along with mum or dad or their carer. And that's absolutely fine, but please, what we do request is that if you are providing any adolescent school-based vaccines in your surgery or facility, please make sure that they are uploaded to AIR in a timely manner. We do have parents that provide consent for their child to receive vaccines in the program at the start of the year. So often a parent will, diligently fill in their consent for school in February, and then perhaps that student has missed the first clinic at school. So it may not be until later in term 2 that the nurses are going back to that school, and so they are checking every child's air record before they vaccinate. But if that child has received vaccines at their GP and they're not on air, then it does make it makes a lot more work for us. We have to make phone calls to parents and obviously try and get that evidence. So HPV vaccine in Australia, as hopefully everyone's aware, in February of 2023, not only did we have the introduction of the CARMI or online consent portal for school vaccination program, we also moved to a single dose of HPV vaccine. Catch-up was extended and includes up to 25 years of age, people of 25 years of age, and anyone who receives a single dose before 26 years of age are now considered fully vaccinated. So just that single dose is all that we need to see on the record. People with immunocompromising conditions should still receive the 3 doses of HPV vaccine, however, and this information is all in the immunisation handbook. As always, if you're unsure, please contact us at the Public Health Unit. Just pointing out also the reason that we're providing HPV or offering it to our Year 7 students when they're 12 to 13 years of age. Just a reminder of why we're offering it at that point in time. It's because we're wanting to vaccinate those students before any sort of sexual debut at all. Now, that does not mean intercourse. It can just mean touching and feeling of bits and pieces, and they can have exposure to the virus. So we really want to be trying to provide that vaccine early on. There's been studies that show that when we wait to provide vaccine to someone that's 15 years of age, for instance, it actually, a study showed that half of those people had already had some sort of sexual encounter at 15 years of age, so then the vaccine really isn't effective. So we need to provide that vaccine early to make it to give it the best chance possible. In Australia, we're so lucky that we have these vaccines that help protect us against certain cancers, and obviously HPV is one of them. Hepatitis B is the other one, if you're wondering. Okay, so just a quick oversight of some of the coverage for our HPV in our girls in New South Wales. This is historic data back from 2008, and you can see the blue line actually shows the 3-dose schedule. So we moved to, as I said earlier, to a single-dose schedule 2 years ago. Unfortunately, it's a little bit of a bad news story with our rates. As Sharon said earlier in the evening, immunisation rates are on the decline, and this is across the board, not just with our kiddies, but also with our adolescents. There's a lot of talk and around this and trying to work out the ways forward, and so just watch this space. I think there's a lot of work going in at the schools. So for us to get consent is our biggest thing. We need to make sure that we have consent for vaccine, because if we don't know about those students. So that's really where we're sort of trying to focus in Hunter New England Health. And, people are very quick to blame COVID, I think, for the drop in vaccination rates. That certainly has had an impact, but it's not the whole story. Because if you actually look at this slide and carefully, you can see that prior to 2020, there was a slight decline in HPV rates before COVID. So, it's not the whole story, that's for sure. So this is for our boys, the HPV coverage for boys. It is fairly similar to our girls and the rates for girls. I guess I just wanted to add in here that early on when we had the HPV vaccine out there on the market, it was really certainly marketed as a cervical cancer vaccine, and that is obviously one of its predominant uses, is that we want to prevent our girls against cervical cancer. However, there's been so much research to show that HPV vaccine is protective against a number of reproductive cancers, but also cancers of the mouth and the throat. So it is an important vaccine for our boys too. We sometimes have parents that, will say to us, why does my son need a vaccine for HPV? He hasn't got a cervix. Well, actually, it's really protective against other types of cancers and also helps prevent genital warts too. Obviously, so we want to definitely be trying to keep vaccinating our boys as well and keep those rates high. Here's our meningococcal data. So meningococcals always floats along sort of at around sort of 65 to 75%, and no one really knows why. Meningococcal disease is something that if it's contracted, it, makes you sick very, very quickly and very fast and can be missed in diagnosis. So we certainly want to make sure that our adolescents, from 15 years of age are protected against this disease as well. So please, I would encourage you to, if you're seeing adolescents in your practices, to be checking their air record. If they're coming in for other things, please check their immunisation records or be having a conversation with them around their immunisation status to make sure that we are getting these vaccines in arms and we're protecting these vulnerable sort of age groups. We know that meningococcal disease is most worrisome for our little ones, and for our adolescents, because these are the times of our life that we're sharing the most saliva, and this is how meningococcal is spread. So, yeah, please look after our adolescents. So elimination of cervical cancer. In Australia, we are set to be the first country in the world to not eliminate per se, but eliminate cervical cancer as a public health concern. But to do that, we need to aim to have 90% of our girls and boys vaccinated by the age of 15 years. So currently, and I didn't actually put this data in this presentation, but the data I showed to our school teams earlier in the year, New South Wales immunisation rates for 15 years old in 2024 was sitting around 84%. Now, the data 2 years ago for that group when they were in year 7 was much, their rates were higher than they are now. So I think it will be interesting to see what the rates are like in 2 years' time to see where we're sitting. So there's a lot of people really invested in trying to reach this target, and there's, as I said earlier, a lot of work going on in the background, and everyone's been trying to be creative about ways to get these kids vaccinated. So yeah, just watch this space. Please, if you have any questions at all about the school vaccination program, we have got a specific school vaccination program email address that's there, and there's our just our generic phone number, and we've got our website there too. So don't hesitate to reach out to us at all. Always happy to help. And just a big shout out to our school teams that are out there and our nurses that are online. Thank you so much, everyone, for all your hard work out there. Our nurses are the people on the ground at the schools, and it's not always an easy space to be working when we're dealing with 100 plus adolescents in a clinic. Fair dues to you guys, and just a big thank you for all the work that you do within the program. Thanks.
As always, we are off to a fantastic start with so much information. Thank you so much, ladies. 10-minute break. We'll see you back shortly. Get a cup of tea, go bathroom, and we'll see you soon. Thanks.
A shame, think something new under the sun. You can't take back them things you already done. No. You blame things that you do on somebody else. No. But they all see is you need help. But still you try so hard cover up your games. You try so hard, hoping that one day something gon' change. You waste all of your time covering up your tracks. Spend all your days running away. You gotta watch your back, and that's the facts. You spend so much of your life scheming and trying to get over. Got you wondering why you come around. All you get is cold shoulder. Yeah, you try so hard to cover up your games. You try so hard, hoping that one day something gon' change. You try so hard. Yeah. You try so hard. You try so hard. Yeah. You try so hard. Give me, Can't run away, man. You gon' pay. Still you try so hard to cover up your games. Got you thinking, don't nobody see all this time. Ooh, it ain't nothing changed. A shame, think something new under the sun. You can't take back them things you already done. No, you blame things that you do on somebody else. No, but they all see is you need help. But still you try so hard to cover up your games. You try so hard, hoping that one day something gon' change. You waste all of your time covering up your tracks. Spend all your days running away. You gotta watch your back, and that's the facts. You spend so much of your life scheming and trying to get over. Got you wondering why you come around. All you get is cold shoulder. Yeah, you try so hard to cover up your games. You try so hard, hoping that one day something gon' change. You try so hard. Yeah. You try so hard. You try so hard. Yeah. You try so hard. Give me, think something new under the sun. You can't take back them things you already done. No. You blame things that you do on somebody else. No. But they all see is you need help. Oh, but still you try so hard to cover up your games. You try so hard, hoping that one day something gon' change. You waste all of your time covering up your tracks.
Welcome back, everyone. We hope you had a chance to either grab another cup of coffee, cup of tea, fill up that wine glass, get your cosy slippers on and your jammies and ready to hear another 45, 50 minutes worth of wonderful information. I'm here to introduce the wonderful Jodie Stevenson, back from her sojourn, looking fabulous. So thank you very much, Jodie. Take it away.
Hello, I'm back. I'm a bit excited. Let's get started. My brain is full, so I'm guessing some of yours are as well, but let's do our best to talk about the 2025 influenza vaccination program. Big deep breath. Keep calm and vaccinate, because we've got lots of recommendations that we need to do to keep our community safe. Just a reminder, influenza is serious, just like COVID, and your recommendation for a vaccination matters. Just a bit of a heads up on flu. You can spread flu before you're sick and continue to spread it for the first 5 days, but children get to spread it for up to 10 days. So stay home if you're sick, wear a mask if you have to go out in public. We know this, but I felt the need to mention it again. Okay, so this time last year I was knee-deep in chemo, missed the whole flu season, missed it all, but I looked at the graphs and it was massive. You guys were hammered with a really active year of influenza. On top of that, there was also COVID, pertussis and RSV. I'm so lucky we've got great vaccines available now. So the optimal time for immunising remains mid-April. We don't know what the 2025 flu season's going to look like, but as beautiful Georgia mentioned, it's been a bit of a not good in our northern hemisphere, with children becoming really unwell and hospitalised. No reason to think that our season will not follow a similar line. So it's really, really important that we make good, strong recommendations for flu vaccines. So what's in our flu vaccine this year? We base it on the Northern Hemisphere, as you know. So we've made one change for the A strain. We've now got Croatia in one and the District of Columbia in the other. So just a reminder, our egg-based vaccine and our cell-based vaccine are considered equivalent. We do not have a preference over one or the other. Annual vaccination remains the most important measure to prevent influenza and its complications. It is recommended for all people from 6 months of age. So we're going to talk about recommended and funded, but recommended for everyone from 6 months of age. Healthcare provider recommendation is the strongest indicator to a person having a vaccine and access to the vaccine. Don't make it hard. Don't make another appointment. If flu vaccine is recommended or recommended and funded, please administer it then and there with confidence. If a person had the 2024 vaccine late last year or even early this year, the 2025 vaccine is still recommended for them as soon as it becomes available. Acknowledging the increase in avian influenza, ATAGI notes that seasonal influenza vaccine is not protective against avian influenza virus. However, People in an occupation risk, such as poultry workers, are recommended to receive the flu vaccine to minimise the potential risk of reassortment in the case of dual infection of influenza and avian influenza. Add that to your list as well. And just a reminder, influenza vaccines can be given at the same time as or any interval before and after any other vaccine that you're going to give. This includes RSV, Shingrix, COVID, pertussis, so no spacings required. While protection generally expected to last throughout the whole year, the highest level of protection occurs in that first 3 to 4 months. So this is why we recommend influenza vaccine from mid-April on. However, vaccination should continue to be offered for as long as influenza virus is going around. If influenza is circulating, then it's time to immunise. And this is especially important in case you've got people travelling in the later half of the year, and some of your flu vaccines are going to have expiry dates of February 2026. So what vaccines are we getting this year? It's a bit exciting, isn't it? There's only 3. I understand from last year you had a bucket load more, but this year you're only going to have 3 brands of flu vaccines in your fridge, so let's get it right. Let's not give the wrong vaccine to the wrong person. So check you've got the correct brand for the age of person that you're going to immunise. We have Vaxigrip Tetra. We're familiar with these vaccines. These aren't new. Vaxigrip Tetra can be used from 6 months of age, and it's the universal vaccine. So it's 6 months of age and the 5-year program. It's the Aboriginal and Torres Strait Islander program. It's the pregnant women and the NIP eligible for medical risk. So it's your all-rounder. We also have Flucelvax Quad, our cell-based influenza vaccine. That's for your 5 to 64s, so your medically at-risk group. And then we have again your Fluad Quad, which is for your over 65 people. It's the only vaccine funded and recommended for your over 65s, not available on private script. If you're 65 and over, it's funded and free. Don't give people a script. And just a note on the product information for Fluad Quad, it recommends the vaccine be gently shaken, not too hard, and then it becomes milky white, and that's normal. So you may have someone outside of the medical risk groups, which are here, and that's okay. Remember, flu vaccine's still recommended for this group. So your healthcare workers, your travellers, your people that just don't want to bring flu into the home, into their family, a script is available. There is no change to this eligibility group. So whoever was eligible last year is still eligible this year. So just a reminder, children 6 months to less than 5 years of age, all adults over 65 years, all Aboriginal Torres Strait Islander people, all pregnant women, every pregnancy, all people with certain medical conditions. Sharon was talking about rates earlier. I'm going to give you a really sad story. Influenza, New South Wales, less than 24% of our 6 months to 5-year-olds were recorded as having 1 dose of influenza on air. For a serious vaccine preventable disease, we're really missing something there. And that's decreased from the year before. So just a reminder, your recommendation and your availability of that vaccine really helps with promoting access to the vaccine. I just want to talk about pregnant women for a moment. So pregnant women who received the influenza vaccine in 2024 but are still pregnant are recommended to have the 2025 vaccine. For pregnant women who had the vaccine before they were pregnant, they're recommended to have a vaccine again during pregnancy. This one is to protect the bub. Remember, there's no vaccine for bub for that first 6 months of life, so bub needs to get protection from mum. I feel like asking, put your hands up if you've got any questions, but I know that doesn't work. But Shaz and Kirsty at the back typing furiously if you've got any questions. So how many doses are we going to give? Just a reminder, this is from the handbook. You don't have to say Jodie says. The handbook says from 6 months to less than 9 years, if this is your person's first ever influenza vaccine, they get 2 doses at least 4 weeks apart. not 2 weeks, but at least 4 weeks later they get their second dose. And then they go on to have 1 dose every year. Everyone 9 years of age and older just gets 1 dose, annual influenza vaccine, except for the pregnant women that we spoke about. And people of any age who have recently had a hematopoietic stem cell transplant or a solid organ transplant, they also get 2 doses for the first year after the transplant. If you come across your little bub who's now 18 months this year and they only had 1 dose of influenza vaccine last year, they still only get 1 dose this year. It's only 2 doses in that first year. There's no catch-up. I hope that's clear. Again, that table's in your handbook. So what resources are you going to get? We're going to get stickers. Make sure you put those stickers on your baskets. Again, we really, really, really want to avoid any drug errors because drug errors leads to loss in confidence of our skills and abilities and the vaccines. So double check you've got the right vaccine for the right age group. Use your stickers on your baskets. And here's a handy table that is in the immunisation toolkit that you're going to download. So your actions after tonight. Discard your 2024 stock if you haven't done that yet. Go in, rummage around, get rid of it all, make sure we don't do any errors. Confirm your pre-allocation order on the New South Wales Vaccine Centre. The Vaccine Centre has advised us it takes around 4 weeks for them to get all first round orders out around New South Wales. I keep thinking we're just Hunter New England, but around all of New South Wales. And then you can start ordering your second lot. Deliveries should start from today. Residential aged care facilities are the priority, then healthcare workers and GPs. So any time from now, you're going to start getting it. Please don't book your patients' clinics until you've got vaccines in your fridge. Otherwise, we get lots of phone calls going, well, where can I get my vaccine? The recommendation is to order enough for a maximum 4 weeks, but honestly, this is only if you've got space in your fridge. Don't overcrowd your fridge. Don't take your vaccines out of their packaging. They're light sensitive. Keep them in their boxes. They're happiest there. Make access easy for your patients. Access these resources and trust your recommendation that you're making. Trust the science behind the recommendation for the annual flu vaccine for everyone from 6 months of age. Just briefly on vaccine safety. This vaccine's been around for decades. It's safe and well tolerated. The most common side effects, pain, redness and swelling at injection site, lasting a few days, generally no treatment required. Sometimes a cold compress or ice pack, generally no treatment. Severe reactions such as anaphylaxis, super rare, and you need to tell us about that. We want to know about those. And just a reminder, the vaccine doesn't contain live influenza. Remember Sharon was talking about live, attenuated and inactivated vaccines? All influenza vaccines in Australia are inactivated. They can't give you influenza. They may pick it up from sitting in your waiting room, but they can't get it from the vaccine or from the car park walking in. People with egg allergy, people with latex allergy, safe to have the vaccine. They're all latex free, and even people with a history of anaphylaxis, safe to have the vaccine. Let's protect our community. Let's keep our hospitals free. And when you're giving your flu vaccine, check and see if they're due for a COVID vaccine at the same time. Go forth and immunise, my friends. I'll hand you over to Kirsty. She's coming forward now. I'll just wait. Oh, here she is. Good night, everyone.
There I am. Thanks, Jodie. So lovely to have you back in our team. We really appreciate having all your wealth of knowledge and experience. Okay, so let's move on to cold chain. I just want to start firstly, though, making a bit of disclaimer here and just obviously acknowledging the widespread storm activity and cyclone activity that we've had across the state of New South Wales and Hunter New England Health. And clearly, property damage has happened and loss of business and things like that, and that really cold chain is just a small proportion of what you guys have maybe had to deal with out there. So I don't want to take away from the significance of what the events have been for a lot of people out there. So yeah, just wanted to start by saying that. So managing the cold chain. It is a growing challenge. It's a growing challenge because we've got this stormy, wild weather that seems to be somehow increasing. We've got climate change there, singing along in the background, and it certainly has been a pretty wild kind of summer. The 16th of January, I like to call that Doomsday for Hunter New England Health. These photos were taken on that day. You can see those storm clouds rolling on in through Newcastle, but also Tamworth, really so much across our LHD. And that meant for a lot of power outages and a lot of providers affected, and the public health staff sitting and rocking in the corner, just waiting for what was coming, essentially. Here are our headlines. It was very significant. Hunter region lashed by another night of storms, and it wasn't just that one storm event. I certainly recognise that too. The area here, there's a headline there: Hunter ravaged by freak thunderstorm. It really had a wide and far-reaching impact. And I recall that day, that fateful day. I had poor GPs driving for half an hour just to find a pocket of reception because all the mobile phone towers were down, and they were just ringing us saying, what am I doing with my vaccines? So I absolutely understand the stress that was happening out there in community. So cold chain breaches. So since the start of January in 2025, we have had 119 cold chain breaches for the public health unit in Hunter New England Health since just January. And 61 of those were just from that Hunter storm event that I mentioned in mid-January. Now, at that time of the year, we had staff that were on the road and out of the office. So there really was just a key 2 or 3 of us that were sort of handling all these breaches at the time. And at this point, I actually want to acknowledge Sonia Davidson, who worked within our team. She now has moved on, but she was actually one of those staff members and really helped coordinate a lot of that work. So just a shout out to you, Sonia. So as you can see, that was a lot of work for our team and has been ongoing since the start of January. So meanwhile, in our public health office, this is how you'll find us. We feel like we're drowning. I think that's probably me there, that funny picture at the end saying I'm doing fine, really I'm fine. By the end of the week, there was certainly moments that, we just felt like we were absolutely drowning, pardon the pun, in reports and how best we can actually help our providers. I just want to also acknowledge here at this point the demographics of the LHD for Hunter New England Health and why it actually can take some time for us to respond or to get advice back to you, particularly when we have such a big surge in storm events and outages. Hunter New England LHD covers a region of just over 130,000 square kilometres. And it's actually 670 kilometres between our Wallsend office to our furthest outpost. So that's, 7.5 hours of driving without any coffee stops between. So as you can imagine, that's a huge number of providers and a lot of vaccine fridges that we're trying to help you manage. And it's not just our GPs, that's our wonderful AMSs and our pharmacies and of course our New South Wales health facilities. So again, that funny little picture there of the cat typing, that also felt like that was us sitting there in our office trying to be as efficient as possible and just really try and support all of you out there. So just some takeaway messages from these storm events. So things that we did as a district on the whole that we did well. Number one, big one, we reported the breach to the public health unit. Big tick for that. Excellent. You guys as providers, you followed all the instructions as per the emails that we sent out that's titled Actions Required to Report a Cold Chain Breach. And these include placing a sign on our vaccine fridges stating do not use the vaccines and do not discard. We also really appreciate those that complete the cold chain breach reporting form as per the instructions in that email. So in completing it as a live document and sending it back. So not printing it out and writing on it and scanning it back or faxing. If you can follow the instructions on the email, it's fairly clear as to how to complete it, and it just means a lot more efficiency from our end because we can then actually import the information and the advice much more quickly. So the other thing we did well is that we downloaded the 5-minute data logging for the entire breach, and we were able to produce that and send that off with our cold chain breach reporting form. We completed our min-max temperature charts from an independent min-max thermometer. So please, not from the fridge. We need to be having an independent min-max thermometer in our system. We have discussed this before, and if you have any queries around it, please reach out. Essentially, the reason we say this, and it is part of Strive for 5, is that you need to be able to calibrate and check your equipment every year. If you're relying on your fridge temperature, we have no idea where that probe sits within the fridge. So you can't yourself, apart from having a fridge service done, we don't know where the temperature reading is coming from. And yeah, you guys as clinicians can't calibrate it. So we need to have that other option in there. And also it means if we lose power, that you've got that battery operated min-max there that's still keeping an eye on temperatures. We send all the required documents to the PHU via our email address, and all in one email, please. That's really appreciated. If we don't get bits and pieces in dribs and drabs, that makes our job a little bit harder. As you can imagine, having 61 cold chain breaches in a matter of 3 days, our inbox got very flooded with cold chain breach reports very quickly. So if people are sending in their reporting form and then they're data logging a few hours later and it's all mixed match, it's very hard for us to keep track of that. Things that we maybe just didn't do so well. So not reporting the cold chain breach to the PHU. And actually I skipped over this earlier, but 8.1% of our cold chain breaches that happened during that big Hunter Storm event were actually not reported to the PHU. We identified those. So Sonia, as I mentioned before, she actually did a ring around in the area to check in on providers that hadn't made contact with us to report a breach. And in fact, yes, they did have a breach, they just hadn't reported to us as yet. So, yep, so we need to report all breaches, please. The other things that weren't done so well is there was an assumption that because you had a loss of power to your fridge and the fridges were sitting at 25 plus degrees that, oh, those vaccines aren't viable. I'll just take them out the fridge and pop them on the bench or I'll discard. That is a real no-no, please. You need to wait for PHU advice before you do anything with your vaccines. The best thing to do in an unplanned power outage is actually to leave your vaccines within the fridge and just leave the door shut, leave the data logging with them, and let's look at it once you've got power restored. The other thing that was happening is that people were trying diligently to keep their vaccines cold in eskies and you know, trying to manage that. But then they're forgetting to actually put any type of data logging or temperature probe in with those vaccines. When we don't have that information at the PHU, we essentially have to make a decision to discard vaccines because there's no way of us knowing for how long those vaccines were exposed for temperatures above 8 degrees. The other thing that we found is that between staff in facilities that maybe there was a bit of an inadequate handover. So when you have multiple staff trying to manage a cold chain breach within your facility, delays can there is a delay of progress of actions and advice when their staff aren't all aware of what's going on. So for instance, if you're a nurse that only works 1 day a week in the practice where you are, and you're the one that mostly looks after cold chain, but you know you're not going to be back for that next week, we need to identify the next best person that can take over managing that breach when you're not there for the rest of the week. In some cases, we had 3 or 4 staff that were trying to manage breaches, and quite often when you spoke to the next person, they actually did not know themselves where things were up to. So we really need from your end for you to know what's going on as well. There's a lack of understanding sometimes about our equipment. So some facilities don't realise they need to have a data logger, but they also may have a data logger, but they're not able to download or provide that information in 5-minute intervals. You need to go away, please, if you don't know how to do this, to understand the steps in that process, because that is what we are going to ask for. If you provide data in any other way, if it's just a min-max form, or data logging, one temperature for every day, that's not sufficient. We need to see it really broken down into those 5-minute intervals. And just on that note, if you have cloud-based monitoring, please don't assume that is sufficient enough not to be actively checking your data. The requirements for Strive for 5 are that you're downloading and reviewing your data every week. So we have got comments about cloud-based monitoring systems where providers have said, well, I just wait for an alarm, and they don't actually, it's always on my phone. That's not good enough. We need you to be actively looking at a week's worth of data and identifying if you notice any temperatures outside 2 to 8 degrees, and at that point notifying us. Don't rely on the technology all the time. The other thing that we found is that with the use of cloud-based data logging, there was an uncertainty about how long the logger would store any data logging and what actually would happen in the event of a power and or internet outage. So some of the data loggers will maybe store data until such time, they'll keep logging and once the internet's restored, it will download a big bulk amount. But that's not for an indefinite period, and really what I would impress upon you again is that you need to make contact with your manufacturers of what equipment you have, and you need to know this information, please. The other thing too is obviously for facilities that didn't return all their documents and their data logging to the PHU in a timely manner. So if we're getting dribs and drabs of information every few days or once a week when that nurse is back in, that really protracts the advice that we provide, and quite often you'll have a stop on your vaccine account for that entire period, and that's really because it's taken this long to get the information. So please identify a vaccine champion or a cold chain champion in your facility, and that person needs to be educating other staff within the facility about how to manage these cold chain breach events in the event that they're actually not at work. So key messages, our vaccines are really special and they need special care, okay? Like you've heard for the last hour or so from, Sharon and Jodie all around these amazing vaccines that we have access to in Australia as funded vaccines. We're very, very fortunate in our affluent country to have these vaccines at our fingertips. And they obviously are very important. They're providing protection against lots of diseases, but big part of vaccines is being able to manage them within the cold chain. So this is important, and I know it gets a bit bland and a bit dry, and I can guarantee you that, in big storm events, like I said, it's, certainly not a fun day for us at the office either, but we need to be looking after these vaccines and really taking special care. Cold chain management is everybody's responsibility. So if you're a GP administering vaccines, you need to have the confidence that that vaccine has been kept within the cold chain and kept at 2 to 8 degrees. We don't want to be having to recall patients at all if there's been breaches that are unidentified. You need to report all cold chain breaches or excursions to the PHU. Now, little disclaimer in this part is that doesn't include temperature deviations where the temperature reaches a maximum of 12 degrees for 15 minutes or less. So that accounts for those moments in time where we're restocking fridges or moving expired stock out of fridges, because obviously we have to have the door open. And if the temperatures go up, then that's acceptable. Just make sure you reset your thermometers. Ensure your vaccines are checked and put in the fridge as soon as they arrive. Make sure the delivery looks to be intact. We've had a few instances in one particular service, actually this past few months, where they've received a delivery and the box has had a huge hole in it, and it's happened twice now. So making sure that you're happy with, before you put them in the fridge, you check that the cold chain breach, the temperature monitor that comes in the eskies before you unload them into your fridges. As I said earlier, ensure you have an independent battery operated min-max thermometer, and I've covered these other things, but make sure your data logger is set to 5-minute recording, and multiple staff know how to download that logger and attach it to an email. Ensure that no vaccines are stored on the floor of the fridge, and always keep them in their original packaging. Please make sure you're completing your Strive for 5 self-audits. If you have not done this already for 2025, I would absolutely encourage you to be doing that now. We want to be making sure our equipment is fine and ready to be accepting our flu vaccines, and it's getting to a busy time of the year. So please make sure all that annual calibration and checking is done. Contact the PHU if you require any support, and do not discard vaccines without consultation. There's just a quick screenshot of the self-audit tool. This is in the Strive for 5 guidelines. Just some quick other tips and tricks. When you're ordering vaccines, obviously we order through the New South Wales State Vaccine Centre. Please do not exceed the capacity of your fridge. And on that note, remembering that we've got our flu vaccines coming. So we don't want to see fridges that are absolutely laden with stock. We want to make sure that we've got our baskets in our fridge and that there's adequate airflow around our vaccines. And it's the responsibility of the authorised practice provider to ensure that the signed declaration is true and the practice is compliant with mandatory vaccine storage and cold chain management requirements. And just remembering that we're only allowed to order 2 routine orders per month for vaccines. So anything above and outside of that, then the Ministry of you wouldn't actually be able to proceed with your order. So yeah, just you really have to be very savvy about the stock that you require, and watch that we're not overfilling our fridges. Okay, so min-max thermometers, like I said earlier, we need to have an independent one. With our min-max temperature graphs, please make sure that you're not only recording the numbers on the chart, but you're also plotting the temperatures. That is a requirement, and it is written on those charts at the bottom. So please make sure that you're doing that. This is an example of how you can plot the charts. Just some other tidbits of information why us at the PHU may put a hold on your vaccine account. That may happen if we've not received a cold chain breach reporting form or the data logging or any other attachments that are required to finalise your CCB. We might put a hold on if we suspect a cold chain breach, or in the event of non-compliance with mandatory vaccine management and cold chain requirements. Or in the event that a deadline is not met. So we will send out occasionally random cold chain audits across the LHD, and you have a window of 2 weeks to complete that information. Yeah, and it's all in emails if you receive one. And again, if you're ever concerned or any questions, please reach out to us. Who do you talk to about cold chain management? So go to your Strive for 5, that's our national guideline. The use of web-based loggers does not replace the guideline requirements. Information provided by data logger manufacturers is not always correct. If you have any questions or concerns about cold chain management, like I've said numerous times, contact us at the PHU first and foremost, and all the time we're here for support. That is our bread and butter, so don't hesitate. If you can't get us by phone for some reason, our email address is coming up in a moment. Okay, and here are the resources. So the cold chain toolkit is also a fabulous one too. Make sure that your staff have all done their vaccine and cold chain management online training. That's training that's a one-off at the moment training module. It hasn't been updated for some time, but just make sure that like admin staff, nursing staff and GPs that are managing vaccines, that they have done this training. What's your name? Oh, don't know. Okay, Sharon's coming now. I thought I had healthcare workers presentation. We'll check that in a moment. But
Thank you very much, Kirsty and Jodie. Fabulous presentations. Just going to finish up with, hopefully Kirsty's got her healthcare worker presentation there somewhere. But I'm just going to roll through some important notes. So lots of little things. When we're doing our presentations, I think we all keep thinking of these great ideas that we need to tell everyone. There's so much information and so much that happens every day in our office that we have always exciting news to pass on to you. So let's give it a roll. Adverse events following immunisation. I know no one ever wants to have one of these happen to them, but if you do so this is anything that you think shouldn't be happening after an immunisation encounter, you need to be reporting that to us. So we have a new website. It's called Immunisation, Allergy, Immunology and Hunter in Hunter, New England. So it's a bit of a mouthful and we've been bundled in with lots of other people. So you'll find us there, and if you go down to information for health professionals, go to adverse events following immunisation and how to report an AFI. You'll find our online AFI report. So this is a RegCap survey, and we encourage you to fill these up, fill this in, and it comes automatically to us, and then we'll be back in touch with you to follow up that adverse events following the immunisation. Put in there as much detail as you can. Photos included. We love to see photos. Vaccine administration errors. So we've just received notification yesterday, and I'm hoping you've all received this alert in your GP inbox, and I hope you've all read it. This is about Abrysvo. Every time we have a new program, we find that there's little bits of issues. People are confused, people are giving the wrong things. So it's turned out that we've had Abrysvo given to children, and we've had Nisivimab given to mothers. So please, we've all been talking about it. Please be very careful that you are giving the correct vaccination to the correct eligible person and for the thing that it's actually registered for. So you need to actually report your vaccine administration errors to us, the local public health unit, and we will probably, our way of collecting that at the moment is by a vaccine administration for an adverse events. Sorry, I'm just watching what's going on in the background. So on your AFI reporting form. So please send that through to us, just stating that it was a vaccination error, but you need to have called us first and had a discussion about it. Okay, so we don't like to hear about vaccine administration errors. Always, you know, the 5 rights: right vaccine, the right person, the right time, and the right documentation. So please just be careful when you're looking at your vaccines. Another thing that we see an awful lot of is you need to give a script for a varicella vaccine, and you actually need to give it for chickenpox. They haven't had their chickenpox vaccines, have no immunity whatsoever, and you want just them to have their 2 doses, if they're over the age of 14, of varicella vaccine. We have seen so many dispensing errors where a script has been written for a generic varicella vaccine and Shingrix has been dispensed instead. And previous to Shingrix, we were seeing Zostavax being dispensed instead. And these poor students that were going for their New South Wales Health employment are being given Zostavax at the age of 18, not registered, not licensed, and not needed and not accepted as a varicella vaccine. So please be very descriptive and pass on to your GPs. You're ordering a varicella vaccine, be very descriptive. Name the vaccine that you require. So if it's for varicella, just chickenpox, Varovax, or Varorix, and if it's Zoster, you order a Shingrix. Sorry, things are on hold. I can't change slides. There's lots of action going on behind the scenes here. Yes, and here we go. I'm hoping you're all really familiar with the additional Commonwealth and New South Wales funded free vaccines page. It's really, really useful because we have our NIP, which is Commonwealth funded vaccine program, but New South Wales also fund extra vaccines. And you can see here that a few have been added. So recently, the RSV has been added because Nirsevimab is actually just a New South Wales funded program. And we also have vaccines for bone marrow transplant recipients. Some of you may not be aware, but up until last year, there were no extra vaccines that were available funded for bone marrow transplant recipients. Last year, they were available just through the bone marrow transplant follow-up teams. But as of the 7th of February, GPs and AMSs now can order these vaccines to revaccinate their bone marrow transplant recipients from the vaccine centre. So once again, when you go on to place an order, it's there down in the bottom, a special button about special order forms, place BMT order. So please be looking after your bone marrow transplant recipients because they are at risk, and ensure that they get their funded vaccines. And for guides on what to give them, there's lots of information in the handbook. And we're ready to go in just a minute. There we go. Another website that we get lots and lots of questions about is Spleen Australia. So people who have had their spleen removed for whatever reason, this is an excellent website to go to. So you just go onto Spleen Australia, spleen.org.au, look up under patients and look up vaccinations, go to the current medical recommendations, and you have these beautiful charts. If you call us for a question about a splenectomy patient, we're going to go to this site and we're going to talk you through this flow chart. 2 pages of people who had not been vaccinated, some who have had previous vaccines, and then there's 2 pages of additional notes as well, explaining everything to you. So please make yourself familiar with that website as well. Our new immunisation schedule, please remember it's been updated since February 2025. So this is only available on that resource as an electronic format, so you need to print it out yourself. What's new? Kirsty's been talking about Year 10 meningococcal now. It's Menquadfi in the school program. And in pregnant women, we have the Abrysvo vaccine in there as well. And of course, the 2025 flu vaccines are on there. So please make sure you've printed out your updated one and have that on your wall. This one's an excellent one as well. So for those who get confused with their different vaccines, this one's got pictures for you. And this is a really, really handy one to have on your fridge for those GPs that like to think that they're going to come and vaccinate a child and have no idea what these vaccines are and can't work out from all the labels that you've got on your vaccines. So a picture is beautiful. So please download that one. That's only for download as well. And the 2025 influenza vaccines have been added with the beautiful pictures on the bottom as well. So anyone can get out the correct vaccines. This is a favourite of ours, the John Hunter Children's Hospital Vaccination Clinic. So you've heard us, if you've joined us last year, you would have heard Dr. Cohen Butters and then Kylie Pratt talking and giving out a wealth of information to you. They run an absolutely fantastic vaccination clinic from the paediatric outpatients up at the hospital, and they love to see kids who either are having difficulty getting vaccinated or where parents have had some hesitancy about vaccination or just lots of questions and want to take a little bit of time. So if you pop onto our website, our new beautiful website, along with allergy and immunology, then you'll see, go down and there'll be a referral form and then you just can fax that through to them and they will be in touch with you. Our immunisation resource form from New South Wales Health, lots of forms on there that you can get, especially the important vaccines for pregnancy, the Aboriginal version and pregnancy vaccines before, during and after pregnancy. Given that we're introducing the RSV season, they may well be handy. I got my supply today to be able to hand out, and the New South Wales influenza information. Oh, bit of a strange thing happening. I don't know what Todd's doing in the background, but nope, can't turn. Oh, there's always something. There we go. Well done, Todd. So this is a really good poster. Along with a poster of the schedule with pictures of the vaccine boxes, this is a really good one as well. Just remember that this is just a guide about where to give vaccines. It's not saying that you have to give the vaccines in these sites, but it's a really good guide, especially for the new immunisers, our GPs who don't immunise very often. It's a really good resource to have on your fridge to give them a bit of an idea. It's also got lots of great information around it. So on the right-hand side, really good clinical advice about vaccination for your new vaccinators, and across the bottom, needle sizes, etc., etc. So you can order these ones from, download these, from NC's website. And PHN have some initiatives. So have a bit of it, contact the PHN. There's a new adult pneumococcal recall program, a funded program. There is immunisation scholarships as well for an EOI, and there's some grants out there. So 2025 vaccination impact grants available. So if you'd like to fill out that funding form, upcoming education. So NCs have got a webinar on triple protection, vaccines for influenza, COVID-19 and RSV in 2025. So please go online and register for that. So that's next week, next Thursday at lunchtime. If you register, you can watch it later. And the biggest education session of all is our upcoming immunisation conference in Tamworth this year. We're moving out to rural. We are really, really excited to be taking the conference out to Tamworth. We have H&E is such a big area, and we have lots of people that find a real difficulty travelling down to Newcastle for our conference. So we're really excited to take it to Tamworth on a Friday, 24th of October. More details to come on that. And I'm just going to do this slide, even though this was meant to be our last slide, and Kirsty's coming up. This is just our team. So call us, we love to hear from you. We have Katrina Clark, Hannah Briggs, our Aboriginal Immunisation Manager, and Hannah is our Aboriginal Health Worker. Myself, Kirsty, Jody, you've met us tonight. Lisa, Gray, Clinical Nurse Consultant. There's the beautiful Deb Parker, our Registered Nurse, and Michelle Harrison and Courtney Priest down the bottom of our admin team that you probably speak to an awful lot on the phone. So I'm going to hand over to Kirsty now, hopefully. Yep.
No worries. So, I'm back. Last lot of slides for the night, so hopefully you're hanging on in there okay. So just a shout out to our conference being out in the country. So I sit in Armidale, so I'm very excited that we're providing a conference to our locally to our rural colleagues. So I really hope to see many of you there at that wonderful event. So I will just whip through this presentation really just about healthcare worker and student vaccination policies. So the policy directive was updated in May of last year. So for those that don't work in New South Wales Health, you can still find this policy directive if you even just via Google. So it's the Occupational Assessment, Screening and Vaccination Against Specific Infectious Diseases policy, and it is something that is for the whole of New South Wales Health, but I'm sure it'll be applicable out there in private practice if you have new staff coming into your facilities as well. Obviously, there are a lot of requirements for our health staff as far as what vaccines they are required to show and evidence of serology. What I will say in the policy is that in Appendix 2, it's actually extremely clear. The policy is, 50 plus pages long, but the Appendix 2 has it very clearly documented for every disease as to what the requirements are and what evidence we need to show to be employed within a health facility. So generally requirements need to be met or at least partially met prior to commencement of employment. Temporary compliance may be issued for hepatitis B, MMR, varicella and TB. That is a new change within the policy last year. So I know many of you are seeing students that are going into health and you're scrambling to try and get them up to, all their records together. So this is a great resource if you keep it there on your computers as a favourite. I will just say at this point that COVID vaccines are now simply recommended for healthcare workers. Obviously, we need to refer to the immunisation handbook about clearer guidance around that and about our vulnerable populations, but no longer is it mandated to have a COVID vaccine within a New South Wales health facility if you're a staff member. So evidence of protection, these are the pieces of evidence that we need to provide. Now, if you have those documents on the left-hand side of the slide, please make sure that all the information is on there. And I understand that Clean Connect, who are the screening kind of service for New South Wales Health, are very, very strict about the documentation. We even had one of our staff say today that her daughter's records were sent back because it was simply missing one little signature on one part, and the rest of it was really thorough. There were batch numbers and everything, so you need to make sure that it's really thorough, or Clean Connect will keep sending it back and saying you're not compliant as a student or a new worker. AIR is obviously our golden thing, that we love to have a record of all the vaccines within AIR. So that's also a great tool to get their immunisation history statement, and also serology if it's required. Just bearing in mind, if you have some older adults maybe starting out in health, they're not always going to have received some of the vaccines that are required to start that position in health. So I most notably will mention here probably hepatitis B. So be aware that Hep B was not on the NIP schedule until 2000. So if you have anyone that is born prior to that time and hasn't travelled, where they may have required Hep B for travel reasons, it's essentially they won't have had any vaccines for Hep B. That's, always looking for documentation first and foremost is where I would start, but just being aware that the schedule that we have today has not been a schedule in existence for the last 40 years. The schedule, as you can see, does change frequently. An awareness about the history of vaccine and vaccine requirements in Australia is helpful, but that's also where you can just reach out to us for some support and think, where am I going to find these records if we have any at all. So on that, hepatitis B, so Hep B is a 3-dose schedule, except for those that are 11 to 15 years of age. It is adequate to provide a 2-dose schedule. This information is in the immunisation handbook. Generally, our current 11 to 15-year-olds that have been born in Australia most often will have had their Hep B course as a little person, so we don't see that so often now. But yeah, so essentially the rule is Hep B is a 3-dose schedule. If someone had that 3-dose schedule 10, 15 years ago, and you've got documented evidence of that, it will be, and then they come to you as a patient in the practice and say, I'm going off to work as a nurse, and they need to provide evidence of serology. It's going to be highly unlikely that they're going to have a positive serology result having had that Hep B course so long ago. So if you do send them for serology and they have no immunity to Hep B, the recommendation is that they have a single booster dose, and making sure that that person goes back to have serology 4 to 8 weeks after that booster dose. So we don't restart a schedule. We just need to activate that immune response by way of recent vaccination to show that serology result. So Hep B antibodies essentially go into hiding. So even though someone has had serology and they've had a course, a few years ago, but they haven't got any immune response, it doesn't mean that they're not immune. It's just because they haven't had a recent exposure to the virus by way of vaccine or disease generally. So it means you more often than not are not going to see that serology result. We need to be doing serology within 4 to 8 weeks of vaccination. Okay, MMR and varicella, we've heard a bit about this across the evening. So protection should be assumed based on the number of document doses received. So we know that we should have a 2-dose schedule for MMR, and depending on your age, if they're an adult, 2 doses of varicella. Now, if you have that evidence for your patients of vaccination and it's an appropriate vaccination course, they do not need to have serology. If that person is now 17 or 18 and they've come to you and said, I'm going to start out in health, and they've got evidence of 2 doses of MMR or doses of varicella on air, you do not need to send them for serology. And quite often you're not going to see an immune response because, again, it's been too much of a window between vaccination and doing that serology. Just ensuring, and I know this has been mentioned, but if we're giving live vaccines, be very, very cautious about doing a pre-screening and making sure you have a minimum interval of 28 days between live vaccines. If you have a patient that requires MMR and varicella vaccine, you can give them on the same day, but you cannot give one today and the other one tomorrow. If you choose to spread them out, they need to be a month apart. And I know Sharon's mentioned this, but I know she asked me to do it again. Please do not give someone Shingrix. If they need varicella vaccine, we need to give that vaccine. We had a case just recently where a student had a documented dose of a single varicella vaccine, and then the GP gave them a Shingrix vaccine and they were rejected by Clean Connect because that's not appropriate. And then, unfortunately, that poor student went back to the GP and got a second dose of Shingrix. We're still waiting to hear advice about that, but I suspect we'll be told that they'll actually need to still have their second varicella vaccine. So no Shingrix, please. Okay, and there's the references. I'll let Sharon just wrap up.
Thank you, Kirsty, for adapting to our different order. And thank you for team behind. Look, I hope you've all had a really good night. I hope we've answered all of your questions and given you lots to think about and to go off now and implement some different things in your practice. We have been working really hard in the background answering all Slido questions, and I think we've managed to answer them all. We're not going to have time for Q&A tonight, and we know that you've been very patient with all of our information. I'd really like to thank the great team. Really great to have Jodie back. Kirsty and Jodie, great presenters, and Georgia, who it was her first time today. So really thankful for the whole team and for the PHN for providing this service for us. We love doing them. So I hope you all had a great night, and please give us some feedback. Give us your feedback. What is it that you really want? But thank you very much. Have a great night.
Thank you so much. Probably one of my easiest events, ladies, so thank you. And to our wonderful cohort at home, you're always so interactive, ask really pertinent questions, and it just makes me so happy that we can provide this because I think it's helpful for everybody. As always, please fill out the Slido. It should have popped up on the right-hand side of your screen. And I'll get the certificates out to you in the next few weeks. Look after yourselves and take care. Thank you.
Shame, think something new under the sun. You can't take back them things you already done. No. You blame things that you do on somebody else. No. But they all see is you need help. Oh, but still you try so hard to cover up your games. You try so hard, hoping that one day something gon' change. You waste all of your time covering up your tracks. Spend all your days running away. You gotta watch your back, and that's the facts. You spend so much of your life scheming and trying to get over. Got you wondering why you come around. All you get is cold shoulder. Yeah, you try so hard to cover up your